All right, let's take a look here. All right, let's make sure everything is sounding good. And then we will go post it on Twitter. And after we post it on Twitter, we'll get rocking and even probably rolling. Okay, there's that. Here we go. So let's just find the video. It sounds like everything's working out. So if everything is still working out, then we're going to get going. Let's take a look. Let's take a look. Let me see if I can post this real quick. And after I post it, we'll get going. Okay. Okay, here we go. Just going to share it. Give me a second here. So sorry for the delay. Okay. Okay, I think we are sufficiently posted, which means that it is time to indeed, in fact, get going. So good afternoon, good morning, whoever you are, wherever you are. My name is Dr. Patrick Lockwood, and this is yet another episode of the weekly podcast called UnShrink Me. So for the purposes of this podcast, I'm not a psychologist, I'm just Patrick. However, this is a weekly podcast if you're brand new to the channel that is focused on mostly consumers of mental health services. And for anyone who's brand new, I want you to understand that the reason I started this in the first place is because I found that a lot of people in higher education were misleading, let's say, their next generation of therapists about what it means to be a clinician and how to help people as a professional specifically. And I also noticed in my years as a supervisor and as a person who hires and fires people that there are a lot of people who are misled and misunderstanding what it means to actually be in the mental health profession. So this podcast is literally a weekly critique of popular common ideas in mental health so that you, the consumers of mental health services, people seeking out family therapy, individual therapy, couples therapy, coaching, counseling, Christian counseling, rehab, etc. If you're out there seeking out services, I'm creating content every week so that anyone who is seeking out services gets the best chance to get the most out of their mental health provider. So that's the spirit of this podcast. It is sometimes very critical, sometimes occasionally humorous. I'm occasionally funny, believe it or not. But the goal is just to provide an open and honest and reasonable critique of what are trendy ideas in psychology and psychiatry and things like that. So that's the spirit of this podcast. It's every Saturday, 3 o'clock or 3:30 p.m. Pacific Standard Time. And as always, this podcast is not an OT, not sponsored by Celsius, though I do enjoy this stuff. So welcome to everyone. We have a lot of interesting things to talk about today. There's a couple of quasi-scandalous posts. I want to talk about therapist personality styles as well. I also want to talk about the war for patient personalities as well. So those are some of the things that I think we'll be talking about today. As always, I like to start off with a softball post. So for those of you who are brand new to this, I always go to Twitter, where a lot of clinicians and influencers live, and try to find content so that we can have discussions. So on this week's episode, jokingly for my friend Nick Tabor, on this week's episode of Ungrist Me, I have a couple of Nick Tabor posts that I'd like to discuss because he talks about it as grist for the mill. Hello, Phil. You're not late. You're right on time. Glad you're here, sir. Welcome to the chat. So there's a lot of interesting stuff to talk about. I want to talk about a couple of easy, obvious things and then get into some more complicated things. So we'll save the therapist personality thing for a little bit, but first I want to start with a softball from Stephen Hayes. For those of you who don't know, and I'm going to retweet this while we're talking right now, his name is Stephen C. Hayes on Twitter. You can find me and the posts that I'm reposting on Twitter at Alobe Patrick at ALOBHAPATRICK. That is my handle on Twitter. That's where this content can be found. So I'm going to retweet this real quick. Okay. So I always like to start with a softball post because I want to start with something easy to warm us up and get us into the spirit of healthy, honest critique, right? So Stephen Hayes, founder of Acceptance and Commitment Therapy, aka ACT, kind of a second/third wave therapy in the cognitive world, said something I think rather useful 3 days ago that I want to talk about for everyone in therapy. So for everybody in therapy, I want you to consider this post. I don't know what specifically it will mean to you and how it will apply to you, so I'm not giving you specific feedback. Don't sue me, etc. This is just a general idea that I think is worth everyone considering. And if you're a therapist or clinician listening, this is even more important for you. He said, this post is for conscientious practitioners who take their clients' stuck points home with them. Slow progress is data, not a verdict. The question is whether something in the approach needs to flex, not whether you fundamentally failed. So here's the picture that he is talking about from his website. Here's the quote that he is discussing. Here's what Stephen Hayes says. Your client's inability to change is not evidence of your failure as a clinician. It is most often a signal that something in the therapy relationship or the model or the timing needs to flex. So let me just start by setting the table with this basic premise, which is people who seek out therapy, counseling, coaching, consulting, whatever, are often conflicted about change. It's, if you read the literature on motivational interviewing, the basic idea is that ambivalence, as in having two or more conflicting thoughts about something, is the ordinary state of human affairs. So conflict or ambivalence are the ordinary state of human affairs. This is our idling speed in our mind, basically. So what Stephen Hayes is saying is that if you're struggling to move forward in treatment and achieve patient goals, perhaps that something in the relationship needs to flex, or something in your model of therapy needs to flex, or the timing of what you're doing needs to flex. So my buddy Ryan is in the chat here. Glad you're here, bud. He says, kind of splitting hairs, you're failing, but of course you are going to fail. Get up and try something else. I think I align with your sentiment, Ryan. What I would say is a little more new agey, at least, is I think we'd use this word failure incorrectly. Right. So I think for most people in therapy land, the world's worst theme park, in therapy land, I think you've only failed when you've completely given up forever. Up until the point that you've completely given up forever, or I guess you die, which I don't want, by the way. I do not want people to die. Until you've either given up completely forever or died, I don't think you've failed. So what I would say is that I don't even think the framing of this is correct as failure. I think if you're having a hard time pushing forward in your relationship with the patient, something is probably off about either how you're handling the relationship, as he said, your model of therapy, your understanding of the model of what you're doing, or the timing of your interventions. You might be pushing too hard, too fast, or pushing too slow, too little. As an example. So I want everyone to hear this because a lot of people come to therapy and get supremely frustrated that they're not where they want to be. People in rehabs all the time have this problem. They walk into rehab with ambivalence about being sober, but the truth of the matter is that while they're in treatment, that ambivalence doesn't magically disappear. Sometimes it gets worse. Sometimes they have so much ambivalence that they want to run away from treatment, and fair enough. And sometimes the ambivalence gets really quiet and they become complacent in treatment. Both of which can be a problem. Both of which can have consequences for long-term recovery goals for people. So I'm saying all this to say that I think his three-part model here is helpful. So if you're out there and you're a clinician and you're finding yourself either feeling stuck or you're feeling okay, but the patient is feeling stuck, etc., you might want to consider how you're handling the relationship, which means you might want to look at their transference or your countertransference as a therapist. Or you might want to look at what your model of the problem is and of the therapeutic change process is, because sometimes you can choose a different model, right? Sometimes a different model is helpful. And finally, the timing of interventions. Sometimes we push too fast, sometimes we push too slow. Ryan says, fair enough. I just want to model that failure is an expected part of success rather than some ultimate state. Yes, I agree with you. I agree with that premise generally beyond even the therapy room. I think failure is ordinary. Not achieving your goal when you want to is ordinary. It's a normal part of change and struggle. And so Stephen Hayes, I think, is correct here in this particular regard. Now, how a therapist might handle it will look different in different situations. However, if you're a patient out there, if you're actively seeking counseling or therapy or something like that, and you are feeling stuck in the relationship, I pray that you learn how to speak up with your therapist. Your therapist is most of the time not fragile and capable of handling your concerns. You're feeling stuck, not like you're getting anywhere, or you're going too fast, or you're going too slow. Most of the time, the clinician can handle it. So if you're in counseling, in therapy, etc., my encouragement to everyone is to speak up and quite literally get your money's worth. Because most people, whether it's insurance or cash, are spending their time and their money trying to change something and understand something better. So I encourage you not to waste it. So thank you, Stephen Hayes, for the grist for the mill, for getting us started here on the Ungrist Me, UnShrink Me podcast. So let's get back to my buddy Nick Tabor. If you're on Twitter or X or whatever, his handle is at NICKTABER. And for everyone who is watching and listening, I have a habit of trying to find posts that he makes because Nick is in the anti-mental health services category, I think, safely to say. He's on the critical side of things, and I have respect for where he's at and for the various reasons why he is in that camp. And so I always like to give people who don't like the profession their fair share, because there are plenty of people talking about how amazing psychology and psychiatry are. So I just want to make sure that, we do a fair job of discussing his ideas and critiquing them as they show up. So on this week's episode of Ungrist Me, as he would say, let's talk about a post that he made yesterday. And there were actually a number of interesting comments to his post, so I'll go through some of those at the same time. So I'm going to repost it real quick. So here's what Nick said about a day ago, roughly a day ago last night. He said, in many cases, the quote-unquote mentally ill role assigned to people through psychiatry and clinical psychology functions as a social gag order, a way to silence the truth seers and tellers. So I have a lot to say about this because I think there's so much going on in this post. It's a couple of sentences, but it's a jam-packed couple of sentences. So let's be honest about a couple of things here. So he said he used a caveat to start his post. In many cases, the mentally ill role assigned to people through psychiatry and psychology functions as a social gag order, a way to silence truth seers and tellers. So I want to talk about this and give it its due, because I think there's a lot going on in it, and it sounds awfully simple. So the simple interpretation is, society is not ready to hear the truth about how screwed up society is, so we call the people who are frustrated with society mentally ill, right? So depressed people are mentally ill because our social systems suck. Anxious people are mentally ill because they're worried about all the catastrophes of life and we're not ready to acknowledge how catastrophic and stupid society is. And so on and so forth. And like, listen, I'm 100% sympathetic to the idea that many people that come to therapy are deep in the middle of very, very sick family relationships, very sick work dynamics and environments, and romantic relationships. And society's terrible approach to culture and values and, getting along and all this stuff is a part of it. So I'm sympathetic to that. I don't think that that's weird or wild or conspiratorial. So I think a lot of people have extra stress or shame or low mood because they do live in really shitty circumstances. And I don't think that that's an individual illness problem, right? Like there's a reason so many people are burnt out in medicine, for instance, because they work often in ridiculous circumstances. In many cases, don't even get paid well enough to work in those ridiculous circumstances. And they burn out over and over again. And there's a high rate of suicide among medical professionals, etc. And so I don't think those people are mentally ill. I think they're in a very sick and corrupt system that says you have to work 60 hours a week to become a physician. And you have to kill yourself in order to save other people's lives. I think that system is inherently pathological, right? So in many ways, I'm very sympathetic to what Nick is saying, which is society is very ill in many ways. Society has really screwed up priorities when it comes to money, efficiency, success, robustness of their businesses, and all these things. I think greed is terrible and stupid, and it kills people over and over again at major corporations and at small businesses. So I agree with you, Nick, that there are many people who are deemed mentally ill when in reality, their symptoms are just a sign of a screwed up circumstance they're in. Then I think there are lots and lots of people who are actually very mentally ill, regardless of how screwed up their families are, or their friends, or their romantic partners, or their jobs, or bosses, or whatever. Like, just to name easy examples. If you have a diagnosis like schizophrenia, and you're hearing voices, there's a really good chance you're not some amazing truth teller who's tapped into the universe through DMT in your brain and things like that. I guess it's possible, but I don't think we have evidence that says that's the truth, at least not yet. So you probably are just mentally ill, right? Like substance-induced psychosis is a real thing, and it's very impairing. It's very risky because it can result in suicide. It can result in accidents and dying that way. It can result in serious violence and harm to yourself and other people. So I'm very worried about people who are psychotic. Same thing with bipolar 1. People who are actually manic, like genuinely, legitimately manic and not just anxious or whatever, those people are at risk of harm to themselves and other people because of impulsivity. So there's a lot of real mental illnesses that are very dangerous. And I don't mean in the sense that they're bad, dangerous people. I mean in the sense that when your mind is out of control and you don't have the metacognition, ego strength, whatever, to wrangle it, you're at risk of harming yourself and other people. And so I think there's a lot of people who are really, 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 really ill. Really ill. And so I want everyone to understand that society is not, quote unquote, assigning a sick role to schizophrenia and bipolar or narcissistic personality disorder or whatever it is. I definitely think in the ecological systems view of things, but at the same time, these things don't seem to just respond to better culture. And I'm open to the argument that they would, but we don't really have data that says that's the case. So do some people who are just trying to, tell the world how sick their environment is get silenced and put on meds and gagged by meds or gagged by therapy or told to just be compliant, good people and fit into society? Absolutely. And I think that's a shame. And I think any mental health professional that participates in that should, double check their ethics. And I think another perspective that's probably not even been said yet is I think a lot of people aren't extra aware of how family systems work and the concept of the so-called sick role works. I think many people who are trained are just trained to see individuals in their illness and not take a full accounting of how sick their system is around them. So for me, I feel very conflicted about this post, dear Nick Tabor. I feel conflicted because, generally speaking, some people are extremely mentally ill and I worry about them. And some people are not even ill and pretend to be ill. And then other people are not ill, but they're really struggling because they're in very sick situations. And so the ability to kind of figure out which of those three things it is the art of being an ethical and useful clinician. And I don't always know that it's always that clear. And so it might be the case, right, if you go back to old family systems theories from the 80s and 90s, it might be the case that, if you look at old school family systems theories, it's like in a triangle, which is three people who are kind of struggling to have healthy relationships. Maybe it's two parents and a kid, right? Maybe that kid develops a drug problem to act out to show that there's fire. Where there's smoke, there's fire, that there's a problem in the family. So the kid starts to act out because the kid's not getting their needs met. But in reality, that kid is just a symptom of the family system where the two parents are all screwed up and cheating on each other and yelling at each other and all this stuff. And so that happens a lot too. And so you can certainly help the kid cope with his emotions better and get off drugs or whatever. But the reality is the parents are still that screwed up. We got to deal with the parents that are screwed up. So I have sympathy for that because I've seen it over and over again in Rehabistan, where I live and work. Ryan says, we need way more systems knowledge. I know I sure did. I screwed up a lot in retrospect. Yeah, it's so easy to blame the identified patient, as it were. It is. It really is. So I hope everyone understands that what Nick is trying to say, in my opinion, what Nick is trying to say is complicated. And so I've given you three scenarios, right? So scenario one is where the person is very seriously ill and not just a symptom of a sick society or sick family. Scenario two is where the person's not actually ill, right? But they're developing what we would call symptoms because they're trying to alert society to how sick the family or their school or their abuser, whatever it is, right? And then there's this unfortunate middle ground where sometimes people do develop genuine mental illnesses like PTSD when you're in like an intimate partner violence relationship or an abusive family or whatever it is. And so sometimes it is exactly por qué no los dos, So I want everyone to understand that there's the case that sometimes the sick people are the truth tellers and all this stuff, but often they're not. They're just sick. And so it's up to the profession to get better at screening and asking questions about systems and things like that. And so there's a follow-up post. Nick or Ryan says it's worse than easy. It's heavily incentivized. Yes. So to Nick's point and to what you just said, Ryan, the system, the mental health system, is heavily incentivized to see people as sick. Right? It's financially incentivized to give you a diagnosis of some kind so that we can work with you. And so, yes, the system is partly responsible for the problem, but it's also the education system that's very responsible for this problem, in my opinion. So let's continue on because there are some fascinating responses to his post. So a person that I don't know and I have absolutely no problems with, but I thought it was just perfectly witty what she said. So Taylor, I'm going to just retweet this real quick. Okay. So Someone responded to him about 4 hours ago, responded to Nick about 4 hours ago and said, and I quote, "The noble savage view of mental illness doesn't help anybody, including the mentally ill. Mental illnesses are considered disorders for a reason," which I've talked about here just now. So I said I really like the use of noble savage in this context because if you don't know what that phrase is, at least this is my rough understanding of it, it's this mythology that Native Americans in the United States were somehow like super peaceful, super loving, farmers. They were never violent. They were just like wise, brilliant people who lived in sync with the land, and they were like hippies or something like that. And the truth is, as we all know, that's a myth. Or if you don't know, I hope you understand that it's a myth, because of like the vast majority of people that lived in what we call the United States before it was the United States were often murderous and violent and horrible and nasty. So I think it's like whitewashing, so to speak, First Peoples or whatever. But I do appreciate how it was used in this context, because the critique that I think Taylor is having of Nick is that he's trying to whitewash people with mental illness as merely victims of a screwed up society, screwed up families and things like that, which is partially true, but not the whole story. Nick was not a fan. And then Dr. Annie Hickox, her handle is at DRANNIHICKOX, said, just real quick, I'm going to retweet it so everyone can see it. She said, "I guess being portrayed as a noble savage is preferable to being viewed as morally weak. But both caricatures bear no resemblance to the truth," which is what I was saying earlier. So there basically are, in the online world at least, and in graduate schools, unfortunately, there are kind of like two different caricatures of people struggling with symptoms of mental illness. One caricature is the noble savage caricature, which is these poor victims of society and economics and greed and discrimination and all these things, all of which I acknowledge, by the way. And then the other caricature is they're just morally weak. They're cowards that don't want to go to the gym. They're idiots who are too stupid, and they don't care enough about themselves and their family to do things to manage their depression better, right? So there's the two contrasting caricatures that are showing up in mental health circles and all that stuff, and just neither of them is true, because people are extremely complicated. I know that sounds probably like a weasel phrase, but the truth of the matter is people are rather complicated. It's probably true that some people in therapy, I'm probably going to get canceled for this, but whatever. It's probably true that some people, a segment of people, I don't know how large a segment of the pie chart, but imagine there's a slice of the pie chart that's visibly identifiable, where they are cowards, where they are afraid of doing ordinary things to make their lives better. I'm sure that's true. And maybe that's true because they were abused. Maybe that's true because they have a personality disorder. Maybe that's true because they had shitty parents who did not instill courage or encouragement in their life. Maybe it's because they're lazy and entitled. There's so many reasons why people lack courage to do things that they think are difficult. It's also probably true that some people have really idealized views of being mentally ill. It's that TikTok culture of, I can't wait to have a label because the label allows me to get special treatment and special status. Everyone's autistic now, etc. So like, I understand that I'm sure those two slices of the pie chart exist. And I'm sure that there are about 5 or 6 other slices. Some people are genuinely suffering. Some people are genuinely ignorant, right? Some people grew up with no concept of what it means to be anxious because they grew up in a culture where you don't talk about that feeling, because that feeling is a sign of weakness. So there are so many reasons why people might show up as one of the stereotypes that we're talking about here. But these caricatures are not real, in the sense that these are not the reasons why people generally show up for treatment. People are actually wildly complicated. And so deep inside everyone is conflict. Deep inside everyone, and sometimes not so deep. Sometimes it's shallow. Sometimes you can see the conflict. And so whatever your reasons for being in therapy, please understand that you are neither noble nor a coward. It's never that simple. You're a bunch of different things. Everyone is a bunch of different things. And so stereotypes about who you are, oversimplifications about who we are is what keeps us sick and stuck. And acknowledging how complicated we are is useful across different types of therapy, across relationships, jobs, cultures. So I hope that everyone figures out a way to see themselves as more complicated than these caricatures, the noble savage caricature or the moral weakness caricature. Because you're complicated, and it's okay that you're complicated. That's hard to deal with, though. It's hard to deal with our complicated conflicts, our personality pieces that are in conflict with each other, our morals that are in conflict with our relationship needs and things like that. We are complicated, and that's why good therapy is so helpful, because ethical therapists allow us to sit with and see and tolerate these conflicts without running away from them and finding a way to understand them and have some power and agency over them in therapy. So that was a lot for Ungrist Me, but thank you, dear Nick Tabor, Annie Hickox, and her handle is Taylor in AZ5 for all of this grist for the mill. So this is fascinating. But I hope it all makes sense, because it's a lot. So this is yet another episode of Ungrist Me. Thank you so much. Let's switch gears. Let's get into something. Let's get into something slightly controversial compared to what I was just saying. So, last week, I talked about a post that was made by Franny Fanny. Her handle on Twitter, if you're not aware of it, is at proud, P-R-O-U-D, _ Penelope, P-E-N-E-L-O-P-E. So last week she said, I'm going to just read the beginning of it again. Let me just retweet it so everyone can see it. So last week she said, the person of the therapist does matter. This is on April 10th. She said, no matter what one's theoretical orientation, the things that are going to go awry in treatment if the therapist, is not taking care of themselves, it cannot tolerate being the bad object, takes things so personally that they become reactive, is so narcissistic, etc. So I want to talk about this again because I've been having some conversations this past couple of days with professionals from all over the country about this, and I think it's really important. I was actually talking to Ryan, who's here in the chat, about this earlier this morning. So she said that the therapist, the patient, the personality of the therapist does matter. The person, excuse me. She said the person, not the personality. The person of the therapist does matter. So I want people who are out there right now seeking therapy to understand. If you're out there seeking therapy, counseling, coaching, consulting, whatever it is, I really want you to understand just how normal and yet abnormal most therapists are. So you've heard me say, if you've listened to at least another podcast, that therapists are regular people too. And I've said that over and over again. Therapists are basically just like everybody else in so many ways. The reason I say that is because when patients have an idealized view of their professional, they're not having a genuine relationship with their professional. They're having a half-genuine relationship. Drew says, we're cooking with this one. Yes, I think so. Thanks for being here, Drew, by the way. So, to get back to it, Many patients from different backgrounds and cultures have different reasons why they will do things like idealize their therapist or devalue them, or think of their therapist like they see them in movies or TV shows, in books or novels. And all of that's perfectly understandable because we operate on very simple models often when we are in uncertain circumstances. And therapy is a very uncertain circumstance because it's two people trying to have a professional relationship, an intentional professional relationship. And that brings uncertainty because we can't know what's going to happen. We can't know how we're going to feel together. We can't know where therapy is going. We can try to outline what we want each session to look like, but more than likely, things will change with time, with circumstance, with new information. So, Franny Fanny said that the person of the therapist does matter. And I really want to double down on this week because a couple of the conversations I've had recently really opened some people's eyes, and even very senior therapists I've talked to who are analysts or analytically trained have found some of my comments shocking or enlightening. And so I want to spell a couple of things out for patients so that the patients, the people who are seeking out therapy, family members of patients, understand very clearly the type of service you're signing on for. This is my little trying to help people understand informed consent a little bit better approach. So let's walk this out. Franny said the person of the therapist does matter. In therapy, we have skills and tools we can teach people. We can teach you how to diaphragmatically breathe. We can teach you box breathing. We can teach you how to use skills like perspective taking. We can highlight discrepancies that we hear you say and do. These are all skills and tools. But in order to effectively encourage people, motivate people, relate to people, the tool that is the therapist is their person and their personality, their IQ, their culture, their beliefs, their morals, their personality organization or style, if you will. All of these things are what we leverage and combine to have a specific kind of relationship with you. And if we're extra aware as clinicians, we're aware of this thing called countertransference. And I don't want to spend a bunch of time on this. I just want to put it out there that if you're a patient and your therapist is talking to you about how you're having reactions because this person is like your mom or your dad or your ex or whatever, that same thing is true about the therapist. The therapist has reactions to patients when the patient is reminding them of their dad or their mom or their ex or themselves even. So that's what we call countertransference. That's an oversimplified definition. So dear psychoanalyst, feel free to critique me all you want. I don't care for this purpose. But that's a neat and tidy McDonald's definition for this discussion. So good therapists are trying to leverage their personality style, their intelligence, their culture, their values, their countertransference, and use these experiences of the therapist to craft their half of the relationship with you. In the same way that a really good actor is trying to live the character that they want to be for their co-actors in the film. And I'm not trying to say that therapists are just shitty actors or narcissists or something, just so we're clear. I'm not trying to make broad swipes against the profession in this comment. What I'm trying to say is that really, really well done therapy involves the person of the therapist, their culture, their gender, their sexuality, their race, their personality, most importantly, in my opinion, their intelligence, their beliefs, their morals, and their countertransference. I just listed like 6 or 7 things that are all very important. And so good therapists are trying to consider all of these variables on their side of the street as they relate to you and talk with you about their experiences and how they understand and experience you, the patient. So that's a lot of words, but I want everyone to understand how complicated good therapy is. Good therapy really involves understanding the complicated layers of being a professional with a professional ethics code that we need to adhere to, but also being a person and the duality and the conflict between our personal feelings, needs, values, personality trait differences, and our professional obligations. Therapists have lots of conflict too, by the way, not just patients. So I'm saying all this to say that in order to have the best possible relationship with your therapist, it's actually your therapist's job to understand themselves as good as humanly possible. And our self-understanding is always evolving when we have new experiences and take in new information about ourselves. So back to that Stephen Hayes post from earlier in the chat. He said some things might need to flex if you're feeling stuck. And that's often true about the therapist. In fact, I think the best therapists are the ones that understand how to flex themselves, how to be more moldable when the patient is coming at you with a problem, a pattern that's intransigent, for instance. Because sometimes the relationship really is the problem in therapy. It's the relationship between the therapist and the patient that is the issue, and that's why change isn't happening. I would say it's often the case, maybe 70 to 80% of the time. One thing I regularly think about when I occasionally do therapy, but often when I do supervision with my interns, is am I communicating things clearly? Number one. Number two, am I communicating ideas and intentions in a way that they will understand? And a lot of times, it's impossible to know if we're communicating good enough. And Drew just said in the chat here, by the way, very good quote. So let me get to it. Drew said, good enough therapy is more than worksheets and skills. If your therapist is only engaging with you on this level, you're missing a large part of what works. And that large part is the relationship, how you talk to each other, what's happening between you two, what's happening inside you while we're talking about this topic. Transference interpretations, countertransference management. People are complicated. And pretending that there are simple skills that will fix problems that are chronic and enduring is absolutely silly. It is not to say that you don't need those skills. I'm a huge proponent, for instance, on Twitter, of people eating better, sleeping better, and exercising more. I think, especially here in the United States, which is where a large chunk of my audience comes from, I really sincerely hope that everyone who's watching and listening, who follows me on Twitter, will eat better, sleep better, and exercise more. Just make progressive small changes and your life will get better. Progressive small changes. However, eating better, sleeping better, and exercising more will not radically address your childhood stuff, your daddy issues, your mommy issues, your dependency issues, your lack of healthy exhibitionism, your lack of healthy narcissism. Eating and sleeping and exercising more won't do much for those things. But they're necessary for your health in general. And it will create a floor, a foundation upon which you can build healthier narcissism, healthier exhibitionism, healthier interdependence, and all these things that therapy can talk about. Resolving issues gets easier when you don't feel like shit. So maybe do things you can to feel less like shit, like eating better, sleeping better, and exercising more. But those three things I just listed aren't going to magically cure feeling abandoned or something like that. That will never happen. So you can help work through feeling abandoned in good therapy, where you talk about the relationship with the therapist, for instance. So I agree, Drew. I really agree. It's really important to not let the important dynamics get missed just because we're trying to achieve a skill, for instance. Not that skills are not important. They're just not usually enough, right? So to go back to this Franny Fanny thing, the person of the therapist does matter. I made a post the other day. I said something like, and I'm going to see if I can retweet it real quick, because I think it got some people's feelings, honestly. I think it got a lot of people's feelings. So let me retweet it real quick. Okay, so 18 hours ago, literally 18 hours ago, interestingly enough. 18 hours ago, here's what I said. Many clinicians are narcissistically organized and do not wish to admit it, or are in denial about it. Many, in parentheses most, display characteristics of so-called vulnerable narcissism, but have brilliant justifications of their symptoms. Getting their excessive need to be special met by seeking special attention from patients. So if we want to get really deep inside baseball here, this post I made, I think is probably one of the most important posts I've ever made on Twitter. I think. And the reason I think it's one of the most important posts is because, as a narcissist, I love feeling important. But that being said, what I would also say is the idea that you're organized a certain type of way is not something that we talk about in graduate school. It's actually, Drew's like, this is the tweet I was waiting for. Absolutely, we're going to run with it, Drew. We are going to cook on this tweet. So I think grad school in particular is really failing people when they don't help people recognize how they're built. So therapists or future therapists, if you're watching and listening to this, I want you to understand that what I'm about to say is not meant with any mean-spirited intent, just so we're clear. Because then I would be being mean about myself, and I'm not certainly that, masochistic or whatever. So everyone has a personality style. If you want to think of it on a spectrum of 0 to 100, there's the 100th percentile and the 0 percentile. Or if you want to think of it like the normal curve, right? Most people are in that first standard deviation. A few of us are in that second and third standard deviation. Very small percentages of us. So here's what I mean to say specifically. I would be willing to bet that certain professions, especially therapy, pull for or select for people who are more narcissistically organized. People who have a slightly higher average need to be important, to feel powerful, and to feel special, and to be seen and heard. So if you want to think of ordinary narcissism, as in non-pathological trait narcissism, as the need to feel powerful, the need to be special or important, and the need to be seen. So-called exhibitionism is the technical term for that. So if ordinary narcissism is just these three things, I would be willing to bet that a very large percentage of people who come into the profession of psychotherapy, whatever degree level, but the bigger the degree, doctorate, MD, PhD, PsyD, whatever, the more narcissistic they are. They have a stronger need to be special, a stronger need to be powerful, a stronger need to feel important, a stronger need to be seen. And I fully understand the hilarious reality that I am here talking to a camera and talking to people in a YouTube chat looking to be seen. So I understand it, and that's why I feel comfortable talking about it, because I understand it personally. So maybe I'm projecting, and feel free to call me out for projecting, etc., etc. Having been a professor for almost a decade and seeing, cohort after cohort of people come in, and knowing a bunch of people in the university system out here in SoCal, which is a pretty big network of people, thousands of people, I will tell you that I don't think it's just because I'm in SoCal. I think that there's a certain personality style that is more good fitting, let's say, for therapy. I am not trying to say that you're inherently sick and broken and stupid because you're a narcissist if you want to be a therapist. That is not what I'm saying. What I'm saying is you might have a constellation of traits that we call vulnerable narcissism, right? So what precisely is vulnerable narcissism? Just a quick AI chat. It's like these are people that have fragile self-esteem, right? So what that means is, this is true for a lot of therapists, is that they're easily feeling criticized or wounded, and it relates to their sense of self. And they're hypersensitive to criticism. And they usually kind of live in black and white relationships, all good, all bad. So like, as a therapist, by the way, a lot of therapists want to be all good, for instance. And that's why I think it's vulnerable narcissism. Therapists often may use emotional manipulation. We might call it therapy, but it's actually a form of emotional manipulation, just with a consent form. I don't know about the victim mentality piece. They may lack empathy or have empathy that's self-centered, which I think is very true for a lot of therapists. They care more about what they feel and less about what the patient says or does. They have a lot of difficulty with rejection, which is why they hide in individual therapy as opposed to going out in the world and being seen and acknowledged. They thrive on special attention and blame other people for their mistakes. Have you noticed how a lot of therapists are like, I can't believe the patient failed? They didn't fail. It's often the case that you failed and you don't want to talk about it. Back to that Stephen Hayes thing. And they might be a little more introverted. In fact, a lot of therapists are more introverted. So the reason I'm bringing this up, so everyone knows, is again, I am not trying to be mean-spirited. I'm very grateful that I get to be a mentor for future therapists as a supervisor. And I get to be a professor, training, sitting on dissertation committees, researching things, talking about things, lecturing to future PsyDs and MFTs. I'm very grateful for that. So I'm not trying to say how sick the profession is and the profession should go away and die. What I'm saying is I think the profession pulls for people who are built this way. And I think the people who are built this way like to help. Because helping in private, where people need you and have to listen to you, gives you the attention you want. So what I'm offering is that maybe, just maybe, we should think twice about why we're in the profession and what we should work on to grow and live healthier lives, perhaps, so that we can either get better at the work or leave the profession. Or, maybe one then the other. I don't know. Drew said, the Mel Jar on Twitter, if you can find her, she's great. Had a fire tweet this week about doctors. Something like, you'd be short with patients too if you were me. Don't you know how difficult they are? And that's true. It's like that is the problem, is that many patients are quote unquote difficult because of the personality of the therapist. Dear patients, if you're watching and listening, if you're a family member or a loved one of someone in therapy or counseling, I want you to hear this. It's true that your loved one might be very sick. They might have an addiction, PTSD, depression, personality disorder, bipolar, psychosis, whatever. They might be really sick. It's also the case that the people that are in the profession are often rather unwell. And in many cases, they're organized in such a way that they cannot fully recognize and tolerate their own difficulties. And so they hide in therapy as opposed to getting their needs met in other parts of their life. So what I would encourage everyone to understand about the profession is that people are very complicated, and the idea that your therapist is some ideal person who can quote unquote help you feel safe or whatever is not true. What is true is you have a person, hopefully, who has a spine, who has ethics, who believes in their principles, who has respect for your individual sovereignty, who respects how complicated your life is because of how complicated you are and your relationships are. I hope that's the kind of clinician you have. Often, that's not the case. So I hope that everyone can find a way to be extra patient with themselves in therapy, because the person you're sitting across from is imperfect. I would say rather imperfect, if that makes sense. And that person you're sitting across from that calls themselves doctor or therapist or psychiatrist or whatever is often, maybe not always, but often unaware of the ways in which they strive for perfection, the ways in which they, the therapist, wants to be idealized, the ways in which they, the therapist, wants to be the good object as opposed to the bad object, as Penelope said in her tweet. Many therapists are very unaware of their defenses. Many therapists are unaware of their injuries, their needs. Many therapists just genuinely suck at getting their needs met. Many of your therapists are very unhealthy people. They have screwed up relationships. They can't keep a romantic relationship. They have drug problems they can't get a handle on. They have mental illnesses they can't get a handle on. And at least here in the state of California, if you have a condition that's impairing your ability to practice, you shouldn't be practicing. So our ethics board says you shouldn't be practicing if you can't get a handle on these things. But people lie. People self-deceive. I'm not saying I'm perfect. I'm not saying I'm even good. That's why I've actually specifically stepped away from doing clinical work on a regular basis, because I don't enjoy it. And I don't want to do something unethical or unreasonable. So what I would tell everyone is that your therapist is a regular person, but they're a special kind of regular person. Often they're kind of narcissistic or organized that way. They have a personality style, maybe not a disorder. But to be fair, just so everyone knows, there are other personality organizations that exist. Some people are masochistic in their personality organization. Some therapists are kind of psychopathic and sadistic. Some therapists are histrionic. Some therapists are more borderline in their organization. There's a lot of them here in Southern California, it appears. Some of them are kind of obsessive compulsive in their personality organization. And if you don't understand the words that I'm saying about the different styles of personality, as dense and ridiculous as he is to read, there's this really crazy person from our profession named Theodore Milan. May he rest in peace. Peace be upon him. So Teddy Milan created the MCMI, the Milan Clinical Multi-Axial Interview. And Milan has this giant tome of a textbook on personality styles and things like that. But really, these are just heuristics. These are blueprints of how we take in information about the world. And so check out Milan's work on the different personality styles if you're not aware of it. But I want everyone to understand that your therapist can be built different types of ways, and that's why they have specific kinds of relationships with you. More narcissistically organized clinicians really want to be a good object with you. They want to be like a good guy. They want to be a hero. They want to be awesome with you. And that's okay, by the way. That's not inherently pathological. But it could be if it's not managed by the therapist. So I want everyone to understand that your therapist is a regular person. And your therapist is often a special kind of regular person, usually with a more either narcissistic or masochistic or depressive or obsessive compulsive or borderline personality organization. And because they're built in these different types of ways, it might, like, if you really want to have fun with your therapist, or if you're out there looking for therapists, ask them what their personality organization is. See what they say. Sometimes people will stumble over it. Sometimes people have a very straightforward answer. Sometimes therapists will say things like, I never thought about that. Or why do you want to know? Which is fair. So please understand that who you are, if you're out there and you're listening to this and you're in counseling as a professional, or if you're in graduate psychology, or if you're a professor, or whatever it is, I hope that you take very seriously how you're built. I also take very seriously the idea that if we're cavalier and de-emphasize us, then we're going to more likely hurt the patient and not help them towards their goals because we're missing half of what's happening in therapy, at least. Not just countertransference, but also who are you and how do you react to people and why do you react that way? It's not just because of your training. We're not robots. So I hope this makes sense to everyone and to patients and family members of patients and loved ones and all that. I hope you're patient. I hope you're, open to being patient about the change process, because as two people into this professional relationship we call therapy, it can take a long time to understand and work with each other effectively. It can take a long time for the therapist to understand their countertransference and how they're working with the patient to do things better. Excuse me. So all of this is just to say it's really complicated to be a therapist. Many of us are sicker than we know, and we were led on to the public, but it's true, and we should deal with that. So seek out consultation, supervision, etc. So I have gone over my time, so I don't have time for a joke today. I really kind of greatly appreciate everyone who has come out to chat. Drew and Phil and Ryan, thank you for being here. And I hope everyone understands how complicated it is to be in therapy, how difficult it is to actually do therapy well. There's a lot of variables, there's a lot of layers, and it's not emotionally easy for the therapist sometimes to acknowledge those layers because maybe the therapist is ashamed of their own needs, for instance. So I hope this makes sense to everyone. I hope that something you heard today was helpful or challenged the way you saw things. If this was helpful or challenging or interesting, I hope that you like, share, and subscribe. Please find me on YouTube, The Psychology Checkup. And come see the UnShrink Me podcast every Saturday around 3:30 Pacific Standard Time. If you're on Twitter, please follow me on Twitter at Alobha, Lobha, Patrick, Alobha Patrick. And let's chat. Let's talk about clinical psychology. Let's talk about the mind and people and relationships. And as always, this is not professional advice, so don't sue me or fire me or blah, 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 blah. Feel free to cancel me, though. Still waiting to be canceled. Hasn't happened yet. Maybe today. I said a scary phrase like Noble Savage, so maybe I can get canceled. Who knows? But let's get on with it, shall we? And I hope to see you next week. I hope you take really good care of yourselves. Eat the food you need to eat. Get the sleep you deserve. Work out as much as you need to. Have good friends. Make sure you get laid. Have a good life. Laugh. And, enjoy your life. And I hope to see you next week. Same time, same channel. See you soon.